All right, I think we can go ahead and get started. And as people come on, we can just, they can just come on in. First, I'm just gonna say Dr. Yardis did ask if we could please turn our webcams on, if at all possible, during his presentation. I'm gonna let him introduce himself and his background, but just like to start by saying, just remember the learning objectives for tonight. It's to identify local strengths and opportunities regarding behavioral health, examine possible entry points for engagement and advocacy, and connect strength across entities throughout collaboration. So, Dr. Yardis, I will turn this over to you and let you go ahead and do your thing.
Okay. All right, so I know that you've probably all had a lot of Zoom in the past year, a little bit more than a year. I have as well. So in a situation like this, what I would typically want to do is have everybody go through and introduce themselves. I know that's the thing that everybody hates. I'm actually not going to do it because I'm hoping this is going to be really interactive. It's really the only way that it's going to work, and I'll get to that in a minute. So I encourage you to cut me off, stop me. Don't wait to the end of a sentence. Don't wait to the end of a thought. Like, ask questions. All right, I'm going to go ahead and share my screen. All right, so the title of this presentation is Building a Community-Based Model for Behavioral Health. It's something that I've given a lot of thought to probably over the past 4 years, and I'll go into that in a minute. So my name is Dr. Kevin Yardis. I'm an assistant professor and the assistant department head in the psychology department at McNeese State University. I'm also the Kay Dorey Counseling Clinic advisor. The psychology department at McNeese is unique in that we have an undergraduate program, and then the graduate program is one master's currently. That's things are going to change with that. It's one master's program currently and 3 different concentrations. So we have a concentration of general experimental. Typically, students who take that are looking to go into a doctoral program in psychology or a related field. We also have ABA, Applied Behavioral Analysis. Students who are entering that want to become BCBAs, Board Certified Behavioral Analysts. And then we have counseling psychology currently, and that's going to change. And students who go into that typically want to become a licensed professional counselor. And I'm also a counselor. The thing that's unique with the graduate programs is that both the ABA concentration, Applied Behavioral Analysis, and the counseling concentration both have clinics attached to it. That's very unusual. We don't have to, we just happen to. And so both clinics are community-based clinics, meaning that we see people in the community, we do not see students. And they're also the training arm for their respective graduate program. So Kay Dorey Counseling Clinic, you'll probably hear me refer to that, or KDCC, quite a bit. I'm also a board member for the Louisiana chapter of the American Foundation for Suicide Prevention, and the chair of the Lake Charles Out of the Darkness Walk for the American Foundation for Suicide Prevention. We do a lot of work. I do a lot of work with suicide prevention. This presentation is going to be through the lens of suicide prevention, because that's a lot of what I do, and we do a tremendous amount of work through the clinic as well. With this model that we're going to be discussing, community-based model, it's a 5-step community-driven model to address a community's capacity to address health concerns. The model specifically talks about how to address disparities through mobilization. And as I said, this presentation is grounded in suicide prevention education. So what I'm going to do is I'm going to give a little bit of my background about how I got involved in working with suicide prevention and education. Typically, not always, but people who work with suicide prevention have lived experience. That's the way we refer to it. And it's not just with suicide, you can have lived experience in many different areas. I do not. So that means that I did not have a suicide attempt that resulted in, for example, hospitalization. And I've not lost anyone important to me, a loved one, friend, family member, to suicide. So my entry point, and that's one of the objectives, right? So my entry point into this topic was with Sam Houston High School. So I received my master's in counseling at McNeese State University, and I did my clinical work, my practicum internship to become a counselor through KDCC, through the K-Door Counseling Clinic. I went off to get my PhD is in cognitive science, actually, um, not in counseling. And I came back probably 3 years into my program, and I was teaching about one class a semester. Um, and as I was finishing up my doctoral work, and I noticed that things had changed with the clinic from just a few years prior. And at that point, the clinic had a relationship with Sam Houston High School. So in 2014, there were 4 student deaths at Sam Houston High School. At least 2 were by suicide. And sometimes the way that we talk about deaths by suicide are using language that sounds couched. And so we might say at least, because whatever statistics you hear with suicide, the numbers are always higher. It's very difficult to know sometimes whether or not a death is actually by suicide or not. So in 2014, at least 2 student deaths by suicide at Sam Houston High School, 2 educators, Sarah Jo Lee, who was the librarian, and Ken Brown, who was, I think he taught probably some AP classes in history, maybe civics, things like that, who was at Sam Houston High School at the time, realized they needed to do something. So they created what they referred to as the pilot program, Peer Initiative Leaders of Tomorrow. I'm not a big fan of forced acronyms, but they obviously were. And so it is a club that anybody can join, anybody can belong to. Its main motivation was to provide support from peer to peer. And then there were peer leaders in the pilot program. And these peer leaders were to provide direct, not counseling, but conversations with their peers regarding topics that might contribute to suicidal thought, like bullying. And then there was counseling. They recognized that they would need to provide counseling to students who were either self-identified or identified by another educator or by somebody else within the school system as having suicidal thought or behavior. And they needed to provide training to the peer leaders. And so that's how KDCC became involved. All right. So I nearly finished my doctoral program. I was working full-time at McNeese as I was finishing my final year, finishing my dissertation. And I really had no intention of going to Sam Houston High School. The thought, I was a full-time faculty member, the thought of going to a school for, at the time, what at the time was a full day, seemed nearly impossible. There was restructuring of both of the clinics, and it became apparent that I wasn't going to have a choice. I was going to have to go to the school. We had to make sure that we were following through with our commitment to Sam Houston High School, especially with a topic like suicide prevention. You can't just walk away, right? And so my first day there, I think I'm not from this area. I think I've been to Moss Bluff maybe twice before that day. And I figured I'd have 2 weeks to get my bearings and figure out where things were. And so third period, I found myself doing a suicide risk assessment using Calcasieu Parish's risk assessment, which I'd never seen until that moment. And thought, okay, there's something going on here. The parent was called in. We spoke with the parent, and the student went to Memorial Hospital ED to be assessed. And so then sixth period, I was supposed to see another student and found out the student was not there. Student was already in a local psychiatric hospital for an attempt. And so I realized, wow, there's it's something clearly going on here. I'm glad this program is in existence. 2 days later, I was back at McNeese, and I got an emergency call from Sam Houston High School that a student that I just met 2 days prior had expressed that the student was thinking about suicide. So I went back to Sam Houston, did another suicide risk assessment. Again, a guardian was called in, and the student was taken to Memorial Hospital ED and was assessed. And so immediately out of the gate, I realized there's something going on here. We have to make sure that we're supporting this program, but it seems like there's probably something larger. And so I considered creating a suicide prevention education program within the K-Dora Counseling Clinic, and we moved pretty quickly on that. And so we did a fundraiser. We did a silent auction, something I will never do again in my life. It was a great experience, great day. It was a lot of work, but we raised enough money to create a suicide prevention and education program. And so there's more to the story that will come out as we go through this presentation, but that's essentially, that was my entry point into suicide prevention education. I've come to see it, and you'll hear me say this again throughout this presentation, that I'm very committed to the topic of suicide prevention education within a community, but I've also come to see it as a tool to address mental health and behavioral health needs within a community as well. Okay, so as I mentioned, the community action model that we're going to be talking about is based on capacity building and community organizing strategies, and it's designed to make issues relevant to the community. So this this community model, we came to it in a very odd way. So the work that we started doing with suicide prevention education in the K-Dora Counseling Clinic, I just shared with you that quickly realized, okay, we need to do something on a larger level beyond just Sam Houston High School, created a program, and then we started putting pieces together. And then I started to see, wow, this is a way to really affect change on a behavioral health level within, and at the time I was thinking Southwest Louisiana. It didn't become apparent to me that we were building a community-based model for behavioral health until maybe probably about 9 months into the work that we were doing. So one of the important things I hope you take away from this is that I'm going to give you a model that was based, it came out of San Francisco with smoking cessation. And it came out of a program that was very well funded. And so that was not the situation. I will also say that's currently not the situation with the work that we do with suicide prevention in the locally, regionally, and at the state level necessarily. And so my message to you is even when there are obstacles, if something is important to you regarding a health initiative, find a way. There's always a way. And I do believe that we've done that. But what you're going to see as we go through the 5 steps of the model is I'm going to be very honest with you about how we did not do things in order. We jumped around. We found the partners where we could. And so we'll get into that. So learning objectives, identify local strengths and opportunities regarding behavioral health, examine possible entry points for engagement and advocacy, connect strengths across entities through collaboration. I will also say, and I think this is throughout the presentation too, that this model is focused on, it's basically grassroots. That's what the model is. It's about training people in the community and then having them, the way that we would refer to it if you were, if this was applied behavior analysis, is a force multiplier. I've worked with organizations, and I'll complain about that in just a minute, where the board members believed that they were the only ones to train in a community. So if there were 9 people on the board, each one thought that their job was just to train. But board members and people that you train in a community, what you're doing is you're hoping that they go out and that they train additional people, or that their interactions with other people lead to additional collaborations as well. So we're looking for force multipliers. And so that's one of the reasons that when I found this model that I really liked it, because they weren't taking a look at what can an individual do. They're looking at, by themselves, they're looking at what is the impact that an individual can have by working through the community. Also, one of the reasons that I like this model too is that when you talk about behavioral health, it can be very punitive, right? And I know that you've had a number of different presentations and you're going through this program. And so it reminds me a little bit of in the 80s, it was Just Say No. And so that was Nancy Reagan and Just Say No. And guess what? That didn't work. And then in the 90s, we had DARE, which I think that was the 90s, and nobody really knew what that stood for. Again, forced acronyms, pet peeve of mine. But I have found out it's drug awareness resistance education. And I do believe that still exists, but I'll go so far to say that I don't think that works either. And so what happens is when you've got a behavioral health project, initiative, message to the community that sounds like just stop, it doesn't work, because if it worked, they would have already got people, the person that you're targeting would have already gotten that message from friends and family. And so you wouldn't even be needed. It's very similar in counseling to is if somebody came in to a session room and I sat down and I already knew that they'd identified the issue that they wanted to talk about was anxiety. And all I said to them was, have you thought about not being anxious? So it doesn't work. It hasn't worked in the past, it won't work. And so this model does not do that. It's not punitive. It's about in working to change to make sure that the issue is given the level of importance in the community that it should be. And then it's about working through the system to make sure that the system works for the individual. Okay. All right. Again, please stop me. If you've got a question, if you've got a comment, if you want to disagree with me, I'd love that. So please do it. All right, community action model. So this model is an analysis of social, economic, environmental issues that support or serve as an obstacle to the identified issue. And anytime you're doing work in a community on behavioral health, I don't want to sound negative, but if I think that if you talk to anybody who's got a master's of public health, they would probably agree with me that if you've got an initiative that you're bringing for the first time into a community, and I'll tell you that 3-4 years ago when we started work with suicide prevention education, I used to say privately to the people that we worked very closely with that I felt that this area, we were toddlers when it came to suicide prevention education. I think it was actually worse than that. I think we're probably toddlers now. So we're able to stand, we're walking a little bit, but we still have a long way to go. Do this with an awareness of global structures. And so that's what I was talking about just a minute ago. And so that might look like privatization of healthcare, okay? So if, or it might look like global structures, might look like maybe you have on the surface the correct organizations and agencies in your community to affect the type of change that you want to affect. Again, this model was based on an anti-smoking initiative in the state of California. I'm talking about suicide prevention. So maybe the organizations and agencies are in place, but there's no structure in place to have them work together. There could be redundancy. There could be some huge gap that nobody knows because everybody's in there, and this is overused, but I'm going to say it in their silos. Goal of the model is to promote change by moving the focus away from the individual and to the community, and that's what I mentioned again just a minute ago. It's not punitive. It's not you should stop smoking. It's not have you, and I realize I'm being facetious, and I hope you realize I'm being facetious, but it's not have you thought about not thinking about suicide. I find with suicide in particular, two things happen. I hear this a lot from parents and guardians. I hear it a lot in the schools is you get advice. You get, well, think about how great everything is for you. You're the captain of the football team, or you just got accepted at Cornell. I hear that type of thing a lot. And the second thing I hear quite a bit is people will share their own personal stories. I remember feeling the same way that you do right now when I was your age and I got through it. So those two things on the surface seem like they make sense, right? Giving advice and sharing your story, not helpful in the moment, because what it does is it takes somebody's story away from them. It might be helpful maybe 3 months down the road, maybe 2 weeks down the road. But in the moment when somebody is thinking about killing themselves, and they are allowing themselves to be vulnerable enough to approach an adult that they care about and that they trust and say, hey, this is what's going on with me. I'm thinking about killing myself. The advice and the sharing your own personal story, it takes what they're sharing with you away from them, and it puts the spotlight on you. A lot of times that is unintentional, but that's what happens. And that's what we're talking about with moving the focus away from the individual and to the community. That's part of what it is. Assist people in acquiring skills to do it themselves. Again, focus on the community, not necessarily on hospital systems or on large entities. I'm just making sure I'm covering everything we wanted to cover with this. All right, so we've got the actual model here. All right, so essentially the model is circular, which is another reason that I always liked, that I've liked this, the community action model, is because I've always envisioned it as circular without an end. There is an output, of course, but it's much like the concept of a theory. If we're talking, not the colloquial sense of theory, but the actual use of scientific theory is circular with some output, but then information comes back in. And so I like that. So train, define, analyze, select action or activity, and maintain. All right, so I've mentioned that as I worked in suicide prevention, I came to see it as a tool to address mental health concerns in general. And so it became clear that we were creating a community-based model. And as I mentioned, I found this model after we'd already begun our work. We were probably about 9 months in, maybe 12 months. And so I want to focus on, I want you guys to focus on what we've done, what I'm going to share, because I'm going to share what we initially did. I'm going to share what we didn't do. I'm going to share things as they stand now. I'm going to share mistakes that we made along the way without having a model like this in place. So I want you to focus on what we've done, where we are, and how it does or does not fit with the model, okay? Because one more time, I want to encourage you that if there is an initiative that is important to you, or if you find yourself at some point in your career where you are working on some type of behavioral health, mental health issue in the community, that it's not going to be perfect. You won't be able to pull out a model and work the model exactly as it exists. This model was based on something that was extremely well funded. The money came from the state of California sued Big Tobacco, and the money that they got legislatively was required to be used for anti-tobacco initiatives. So they were funded from the beginning, and the state could not say no. So that is not always the case when you're working in the community. That was not the case for us as well. All right. All right, we're gonna come back to this a little bit later too, but this model, and I told you it was going to be very transparent. This model, when I looked at it for the first time, I was having some trouble understanding the difference between what they were considering an action and an activity. Part of it was because, again, we did not have a model that we were working. We were not well funded, and so our actions and activities basically looked the same. We weren't sitting down in meetings. Eventually we were coming up with what is our goal. We were doing that on the fly. We had goals. We were talking about goals. Sometimes it was through text communication. Sometimes it was through Facebook. Sometimes we would meet for lunch, the various partners that we have, but we weren't in the beginning having meetings listing out our goals with expected outcomes. So the actions and activities were very much tied together. All right. So an action compels another entity to do something to change the environment, the place people live, for the well-being of all. It's achievable, is long-term or sustainable, and an activity is an educational intervention that leads up to and supports an action. All right. So questions I want you to think about, and please, again, like I do want you to think about these questions. I want you to, if you disagree with something that we've did, if you if you think that we've, there's something that's missing, be brutal. I want you to be brutal. That's the only way that you're going to understand the difference between having a model from the very beginning and working a well-funded model and doing it in a way that's kind of grassroots. I hope that you all in your careers work with only well-funded projects, but I'm going to guess that that might not be the case. And that's especially true when the project originates from you. If it's something that you're passionate about, and please share that with me too, then it may not be well-funded in the beginning. All right, so I want you to think about what barriers are there. What are the community strengths? Are any strengths not utilized? Who is missing from the table? What populations are missing? What about lived experience? I mentioned lived experience before. I'm going to circle back to a few of these before we start to go into each one of the aspects of the model. Are there multiple organizations, entities working on the same issue? That can certainly be the case when you are, well, let me go back to who's missing from the table. And I'll talk a little bit about specifically about suicide prevention. So the first meeting that I went to regarding suicide prevention in this area, it was a coalition. I'll stop there. It was a coalition, and I knew only one other person at the table. There weren't a lot of people. There was maybe 8, and people would come from large agencies, large organizations for this coalition, pretty typical coalition. And I sat there and I got, the history. It was my first meeting. I got the history of the coalition. It had existed, then it didn't for a long time. But one thing that I noticed when looking around the table was very homogenous, very homogenous. It was entirely white. We were all white. And it was my first time meeting most of these people. And I thought, Kevin, don't say it, but that can wait till the next meeting. But I don't typically hold back. And so at the end of the meeting, I did speak up and say, we're all white. And if we want to address suicide prevention within the community, we have to reflect the community that we live in. And that's important for behavioral health as well, is that if you're missing people at the table, then you're missing the story. And even if your intentions are very pure, that you truly want to make a difference, you're not going to make the difference that you think you're going to because you don't have all the voices at the table. Okay. Lived experience is extremely important for suicide prevention. It's very important for many different topics as well. At different points in different meetings that I've had, we've also not necessarily had people with lived experience at the table. Depending on what exactly we were working on at the time, maybe was less important, but we need that voice. Otherwise, and I've seen this in the work that I've done, it can become talking about suicide rather than actually affecting change. It can become about the process. It can become about the bylaws rather than making change in the community. Multiple organizations, entities working on the same issue. If this is a passion project of yours, that very well may be true. And depending on the size of the region, we've certainly had in Southwest Louisiana, multiple organizations doing very, very similar work with suicide prevention. We just weren't aware of each other. What's the nature of the relationships of the organizations and entities? What if a client has multiple needs? And so depending on what realm we're talking about regarding behavioral health, the word client is sometimes used. In counseling, we use the term client. In ABA, they use the term patient. Most things that are medical, you use the term patient, right? So regardless of whether it's client or patient, what happens if the client has multiple needs? Something that I'll probably bring up again a little bit later is I thought I was brilliant during one meeting, and I love working with adolescents. It's my favorite group to work with as a counselor. And I was in a meeting, I think it was a post-hurricane meeting, and there was some potential money on the table. And so I was making a play for some money to create what I've learned is actually called an assessment center. I'd never heard of that before. And so an assessment center, the one that we have in this area is specifically for adolescents. And so what it is a multi-agency center. And my work with suicide prevention in the beginning was largely with adolescents. And what I was seeing is that when an adolescent was discharged from a local psychiatric hospital, it really felt like multiple people and multiple agencies were dropping the ball. And so there's supposed to be a treatment plan. There's supposed to be counseling required, but I was finding that students were it felt to me, in my opinion, that students were dumped back into the school system with no action around that plan. Sometimes what can happen too is if we're talking about suicide prevention, or we're just talking about maybe the student is involved in juvenile justice, what I was seeing is that the student would sometimes have to, or the adolescent would sometimes have to bounce from agency to agency or person to person to figure out exactly which resources would be best for them. And that's what an assessment center is and does. So what if a client has multiple needs? Hopefully, whatever areas you end up working in, there's going to be an assessment center. Okay. What is the state of collaborations in the community? You can also find too that maybe two agencies, what they contribute to the topic that you're interested in, they are definitely existed as a strength in the community, but maybe they don't work well together. Maybe the two people who are in charge of the topic that you're interested in don't like each other. So what is the state of collaborations in the community? What is resistance to addressing the issue? One thing that I saw with suicide prevention very quickly is a lot of resistance. I'm going to be real honest again that schools and school districts do not want to talk about suicide prevention. You, of course, will find individuals within a school and within school districts who are open to addressing it because they realize the seriousness of the issue. But what I found is no school wants to be known as that school. And school districts are also concerned about liability too. So this is the kind of stuff as you're working in behavioral health that you're going to find that you think that you're going to, again, you've got the topic that you're really interested in, but you're maybe not expecting to encounter resistance. And how do you overcome that resistance? And what needs are not addressed? All right, so I do want you to think about these questions. I do want you to interrupt, stop. Otherwise, I will come back to these questions after each one of these breakout slides. All right, so the first topic on the slide, the model slide, the image was train. And so what the model is talking about is, again, well-funded due to tobacco money. And so they identified a group of, I think it was about 15 community members, and they trained those community members to serve as advocates in the community, advocates for whatever anti-tobacco initiative they had going on, okay? So they get, it's very formal training, very significant training, not just in the topic at hand, but how to be an advocate, because for some people that's very natural, but for others it's not necessarily natural. So we were not able to do that initially. With train, name the issue and choose the area of focus. We already had that. We knew that it was suicide prevention, and train participants. So again, we're talking about developing skills, increasing knowledge, and building capacity. So we did that, but we did that through the two places, through the pilot program, which I've already mentioned, Sam Houston High School. And so that was established for a very specific reason, but training was part of that program. So all of the peer leaders at Sam Houston High School got training from the Kay Dorey Counseling Clinic in order to talk to their peers about issues that contribute to suicidal thought and behavior. Later on, and by later on, I mean much later, the Kay Dorey Counseling Clinic, we applied to become a United Way partner agency. Part of that is, it was a long process at the time. So we started in November of 2019 and we were approved in July 2020, right in the middle of COVID. And so the money that we got from that partnership, we had decided to train 3,600 people in the community on QPR, which is suicide prevention and education training. It's evidence-based. I'm sure you've heard that term before. It means that there's research to show that it's effective. And QPR is question, persuade, and refer. It's a really, really basic training. It's not a high-level training. It's appropriate for nearly anyone, probably about age 16 and up, probably. And it teaches people how to question, say the words, because that's an important part of suicide prevention education. We talk in euphemisms about many different things. And so death and anything around death, we rarely use literal language, especially when it's suicide. Adults do not want to talk about it, And so the question is teaching people to say, are you talking about suicide? Are you talking about killing yourself? To actually say those words. Persuade is to persuade somebody to seek help because they're thinking about suicide. People who are considering suicide, many times in general, people think that that their intent is to die, and that is how you define suicide. But the fact is, more often than not, they're ambivalent about living, okay? And so the persuading somebody to seek help may take a bit of effort because they're ambivalent about receiving help. And then refer. The refer is, of course, referring them to services. If somebody is thinking about suicide, they may need support in the form of, I'll sit here while you make the phone call, or why don't we go to the agency together? I'm going to drive you to the agency, that type of thing. All right. So for train, we did do one initially. Again, it was the pilot program, but it was a very small, very training on a micro level for one specific school. And we call it the QPR initiative, is much larger, but the same kind of feel to it. But what you'll notice is, unlike the model, we didn't sit down and do this from the beginning to train advocates. We were training people in specific things, right? And so, and one was initially part of what I see as kicking off suicide prevention education here in Southwest Louisiana, the pilot program, and one came much later. All right, so thoughts on training? I'm not above calling on people. All right, so training. So what we're talking about is training advocates, training them with specific knowledge, in California's case about tobacco, but also training them how to advocate, okay? So questions, comments, thoughts, asking me, why didn't we do this? Why didn't we do that? What would I have done differently? Come on, y'all. At least one question, at least one comment. And somebody, all right. How do you evaluate your trainees? Thank you, Megan. That's an excellent question. That's an excellent question. I'll speak specifically about the pilot program. This isn't exactly about evaluation. That's why I love this question, because that is something that I've been thinking about quite a bit. All right. So for the pilot program and for the QPR, we don't have evaluations exactly. We get, for the QPR, the individuals that we've trained to be trainers, we get feedback. And sometimes the feedback is rough to hear. I don't do a lot of training in the community right now because of the number of initiatives that we've got going on, but sometimes the feedback can be tough to hear, and then we go back to that individual. But there's no formal evaluation for QPR yet. That is proprietary information, and we're not allowed to deviate with that training even by like a single slide or a single word. With pilot program, again, this isn't about evaluation, but the selection process is, I like to joke that the selection process was more rigorous than when I was hired at McNeese. I was here as a VL for a long time. Anyway, so the pilot program, students cannot have had anyone close to them attempt or die by suicide within the previous year. They have to be nominated by an educator. There is an application. There's also an essay as well. They have to have been in the pilot club for at least the year prior, so it's only seniors. And they have to go through an interview process, and it's 3 individuals interviewing all the potential applicants. It's really, really a very rigorous process for selecting the peer leaders in the pilot program in Sam Houston High School. And I was impressed with this program from the minute that I heard about it, because with suicide prevention, one thing that I always say, and this is something to think about with behavioral health too, is there's as much opportunity to do harm as there is to do good. And it's something that you really need to think about. All right, so I've got that one question. All right, to ensure they were trained properly and able to offer to be an effective advocate. Yeah, that's it's great. It's a great question about the evaluation, and it's something that I have thought a lot about. So with the pilot program, that is handled, and that part is owned by CPSB. And so the selection process is very, very rigorous, but evaluation process is something that's going to have to be addressed for any of the train the trainer type of initiatives that we have in the community. All right, let me move on. Not sure if I'm moving fast enough. All right, so diagnose. So this is where, according to the model, where you're going to design and implement tools that are going to be used to assess the extent of the health issue in the community. And so again, in California, what they did was they sat down and they came up with their own tools, okay? And it could look like surveys. And so we did not do that. Now there is in public health, and I know that there are a number of people at Swallow Heck with MPHs, and so I'm sure that they could tell you this too. So there are a number of really great community assessments out there. We didn't do it. And again, at some point we might do that. There is some data out there, but getting something with suicide prevention off the ground, it took all hands on deck. And we started with a very, very small group of people in this area. Some things that we did do to diagnose and understand the state of the issue at the time was we interviewed people who were already engaged with suicide prevention. By interview, I mean, it might have looked like a lunch meeting. It might have looked like, a relationship through text for a while until a meeting could be scheduled. So it could look like meetings and interviews. We did look at existing data. There's not tons of data. We get our data, the most recent data locally regarding suicide deaths from the coroner, and that's where we get it. Regarding state and national data with suicide prevention, everybody gets their data from the CDC. Everybody does. And even if it looks like it's coming from the American Foundation of Suicide Prevention, if you look closely at the bottom of some slide or whatever you're looking at, it's coming from the CDC. Everybody gets it from there. There's also a national death registry. You can get some different information there about attempts. So we did diagnose to the extent that we could while we were still trying to create initiatives within the community. Is there a question? Yeah, California. Okay, so the question is, did California involve the community in the assessment? So yeah, they did. And I believe that a number of the advocates that they had were adolescents. And so they did involve the community. They did a very formal process. The model that we're talking about came from this specific anti-tobacco initiative, and they sat down and they went through a very formal evaluation of what was going on, what agencies are already doing work with regarding tobacco, what policies are in place regarding tobacco, like how many billboards are in the area. And so they certainly did involve the community. They were talking to churches. They were talking to maybe local leaders as well. They absolutely did.
Thank you.
Sure. So what we did was we examined entities. And so I mentioned that we were talking to people in meetings, maybe text conversations, that type of thing. We were looking at the data that we had access to. And so the existing entities that we looked at was, of course, the pilot program, because that's where it all started as far as I'm concerned, that this program existed, and we looked to see, well, what's going on with this program. One thing I heard again and again and again as I started my work with suicide prevention education is this needs to be replicated. In fact, when I met Sarah and Ken, who I mentioned before, my first time meeting them was with, I do a lot of work with suicide with the Dean of the Burton College of Education at McNeese. And I said just those words, oh, this needs to be replicated. And they looked at each other, and I saw them shoot a look at each other. And I said, I'm like, that, obviously there's more to the story here. And so they shared with me that, that people say that, everybody says that. And the fact is, the reason that the pilot program worked is because it was so incredibly tightly controlled. And again, working with suicide prevention, as much opportunity to do harm as to do good, right? And so that interview process, that's when I realized it, when they explained to me the vetting process for these students who are going to be peer leaders, then I got it. So we examined existing entities. For me, it's kind of the gold standard about the selection process. KDCC, an existing entity for as a community counseling agency. However, my thinking was we could do more. I'm just one person, but if we had a suicide prevention education coordinator, suicide prevention education program, then we could be a force multiplier out in the community. And I hope I'm not skipping ahead, but I knew that my full-time job is a faculty member. I'm also a counselor, so I see clients, and I do a lot of work in this area. So I knew that in order for this to be effective, we needed somebody to run it. So we're kicking off some collaborations here. So we worked with IMCAL, which is Imperial Calcasieu Human Services Authority. It's a local governing entity in the state, meaning it's semi-autonomous. It has connections to the government on a state level, and but it is also autonomous to some extent. Often what happens is behavioral health funds, when they come into the state, they go into one of our local governing entities. We are region number 5. I'm getting that right. Region number 5, we've got a great relationship with the executive director there, and they agreed to pay for a suicide prevention education coordinator for this program. It gets more complicated from there, but I'll just leave it at that. So I already mentioned IMCAL. We looked at existing entities. IMCAL had a suicide prevention coalition. And then AFSP is a statewide, it's the largest national nonprofit for suicide prevention training, research, and advocacy, okay? And so we looked at that board. Sarah was the co-creator for the pilot program. Ken Brown was the other co-creator. He was already on the board. And that's how I got involved in the AFSP. And one of the things that I noticed immediately was that it seemed that the board was talking about suicide. So there was an opportunity there to create some change as well, okay? And Swalahek, and you guys all know Swalahek. They're a great partner of ours. Did somebody else have a question? Let me see. Okay. Analyze. So according for this model, after you diagnose where the state of the area, then what you're doing is, again, you're looking at what you found and you're preparing findings. And a lot of times you have actual data, okay? And so you're taking a look at that, and okay, so you're taking a look at what you found, essentially. Analyze results of community diagnosis. So when we diagnosed what was currently existing in the community, I'm gonna be honest about this. I was not a fan of the existing suicide prevention coalition. Again, felt that we did a lot of, each meeting seemed the same. We weren't getting a lot done. We weren't getting anything done. And so one thing that came out of that diagnosis, we analyzed, and Swalahek created a suicide prevention coalition. It's important to not create redundancy, but it's not redundant if one entity is getting work done in the community while another is not. I already mentioned that part of the analysis was the KDCC Suicide Prevention Education Program. That was through a collaboration with IMCAL and Swalahek and KDCC and McNeese. So you can also see too that, and I've heard this a lot in suicide prevention, is people talk about three-way partnership or four-way partnership, because often it can take like multiple organizations to get one thing done. Another part of the diagnosis for me was, that I'm a faculty member. I teach undergraduate psychology, I teach graduate counseling, and the counseling program at McNeese State University is not CACREP accredited. I hear it all the time from people. I hear from the students, when is that going to happen? I hear from the community. People will stop me in a restaurant and ask me about CACREP. And CACREP is an accreditation, and accrediting bodies, what they do is they set a standard for some discipline in this case. And so it's something that I've always been interested in. We've been working on it behind the scenes. We've made significant progress, but we need 3 PhDs in counselor education. We've got 2. I'm working on getting the money for the 3rd. We're already changing the curriculum in the program. I've created, we're having one new graduate class in the fall, a new undergraduate class in counseling, and a class specifically for crisis intervention in theory. So what I did, and it's taken a lot of effort, many years of budget cuts to higher education in the state. And so part of the crisis intervention in theory graduate class, this is where suicide prevention and education will now have a permanent home. And so any graduate from the counseling program, whether it is clinical mental health counseling or school counseling, going forward in a few years, will have very specific training in the Columbia Suicide Severity Rating Scale, which is the gold standard for risk assessment for suicide, and also in the SAMHSA, which is I saw some head nods with SAMHSA. It's for me the gold standard for a safety plan, and we didn't have that before. So what I was doing was piecing together our counselors' knowledge, our future counselors' knowledge regarding suicide prevention when I could, by hosting trainings, by having people come to the area and train, by putting it into their clinicals, but now it's gonna have a permanent home. So this was another part of the analysis. And another part was we knew that we needed to become a United Way partner agency so that we would have money to do trainings in the community. All right, select action and activity. I already talked about action compels another entity to do something or change the environment, is achievable as long-term or sustainable. Activity is educational intervention that leads up to and supports an action. So action and activity. And again, I think I told you when I first found this model, I was having trouble teasing apart the action and activity because for us, they were the same thing. Like the action, it almost immediately led into the activity. And so I can give you some examples like Charles Out of the Darkness Walk. I mentioned this before, that's for the American Foundation for Suicide Prevention. The walk is to bring awareness to suicide prevention. Okay, it's also a fundraiser as well. I'm gonna give you more information about that a little bit later. This walk, the Dean of the Burton College of Education and I took over as co-chairs in 2019. And neither of us had shared a walk before. It was a lot of work. And it was a lot of discovering on how to execute a walk. And we weren't really sure what the day was going to look like, despite the organization that we put into it. And so we had, it went really well. We had a couple state legislators come and speak at the walk, and we had about 1,200 people show up for the walk, a little over 1,200 people for the walk. We hit our dollar goal for AFSP. So the action was greater awareness. It compelled an entity to do something or change the environment, is achievable, sustainable. So what that, for me, in my opinion, the greater awareness of the walk compelled the community to realize like, wow, 1,200 people, I mean, maybe, for example, many people at the walk had lived experience, had either had an attempt or lost a loved one. That was very, very common. But many people during and after the walk told us that they didn't realize that there were so many people with similar lived experience. It also showed people without lived experience too, how many people were invested in this issue regarding behavioral health. So the action was greater awareness, and the activity, what we did for the walk was outreach, media, and the walk itself, of course. So I've done a lot of outreach regarding suicide prevention. It's very, it takes time. It can be very messy. I have a lot of meetings where one of my graduate students might ask me, what's that meeting about? I'm like, it's about discovery. And I've become a big fan of saying it's about discovery when you don't really know what the meeting's about. You just know that there's somebody who's doing some similar work to you, or there's maybe some overlap, or there's a future collaboration there, but you don't know what it is yet. So you just have lunch and you figure out what the, how the two of you fit, how the two organizations fit. So that's outreach for me. Media, a lot of media. If me at this age had told me at 20 years old that I would be doing media, I do a lot of KPLC, a lot, and radio, I would have not believed it. But sometimes one of the great things about working with behavioral health is that it challenges you to be the best version of yourself that you can be. It challenges you to do things that you never thought that you would do. I did media starting for the Out of the Darkness walk because nobody else would do it, and we needed to do it. And I won't say that I necessarily look forward to it. I'm going to do some a spot on KPLC tomorrow, but it also doesn't bother me too, which again is a big change for me versus when I was much younger. Trainings were also action and activity. Trainings were also for greater awareness, right? So we train so that we have greater awareness in the community. The activity was outreach again, and also the trainings themselves too. The third action activity that I'll talk about was Louisiana House Bill 53, Act 93. So you've heard me talk about Sarah Jolie, the librarian at Sam Houston High School. She's still there, co-founder of the pilot program, and Ken Brown, who's now at Washington Marion, co-founder of the pilot program. He's also a lawyer, and he's a lawyer who doesn't practice law anymore. And so he wrote House Bill 53, and and he found the sponsors, the legislators in the state of Louisiana sponsor House Bill 53, which became Act 93. And I believe it was in the summer of 2019 when Governor Edwards came to Sulphur, Louisiana, to sign it into law. So Louisiana has always had a law, the Frost Act, on the books, which required all K through 12 educators to complete minimum of 2 hours suicide prevention education every year. It's just that almost every parish in the state has ignored that. So House Bill 53 underscored the importance of that, tracked it in a way that required it. It is also the reason House Bill 53, Act 93, that all K through 12 IDs now have the National Suicide Hotline on the back and the crisis text line. That's that bill. So you can see how one person can have multiple impacts in different ways, right? So not only did this person create the pilot program, but it literally wrote House Bill 53 and enacted policy change at a state level. So this is the type of thing that you might, maybe you're a policy wonk and this is what you want to do for a living. You never know when that opportunity may come at some point in your career. There's additional policy that I'd like to see enacted. With counseling, the only title in counseling that can be billed for is the LPC, the fully licensed professional counselor. So when a counseling graduate student graduates from, let's say, McNeese, and they're master's level counselor, but they're not yet licensed. So they apply to become licensed and they're provisionally licensed for a minimum of 2 years, and it can take much longer. And so you're under supervision for 3,000 hours. Okay, so minimum 2 years, it can take a long time. And so, but there's only one professional, and that's the fully licensed professional that can be billed for. So what does that create? It creates a situation where we have we have a lack of and a need for more LPCs in the community. And so, and one of the contributing factors to that is that when people become PLPCs, provisionally licensed professional counselors, they need to get paid, right? They've just spent 3 years in graduate school, and at some point you have to start making money again. There are agencies that will pay PLPCs, but it's a challenge because the agency can't bill for that person. So you can see how my understanding of suicide prevention has evolved over time, where I also see additional policy that I think would benefit the topic of suicide prevention. And maintain. All right, so maintain is maintain and enforce action and activity. So how do you do that? So how have we done it? With the other example that in the state of California, and one of the questions was about evaluation. So that's also part of the model regarding maintaining, is evaluating it. So in state of California, there were lots of polls, there were lots of compliance surveys. There were many different things that they did to maintain what they had created. What we've done so far here is we've solidified partnerships and collaborations with MOUs. That's something that I am a big fan of, because we had a lot of, in the beginning, collaborations and partnerships that were that came out of meetings, or came out of a lunch meeting, or came out of just, going to somebody's office and talking about, look, I think we can work together on this. So that can work out fine, but what can work out better is solidifying that with an MOU, with putting something down on paper so that everybody is extremely clear on the expectation for their partner. Reassess organizational and individual partners. We've done that over time as well. I mentioned that Ken Brown and myself are on the state board for the American Foundation for Suicide Prevention. One thing that we noticed that a number of board members who just were not coming to meetings. So board membership has changed. One thing that we work to do is involve somebody out of LSU, Ray Tucker. Dr. Ray Tucker is a clinical psychologist out of LSU who works with the Baton Rouge Suicide Prevention Resource Center. And having his expertise on the board was important. The state has a suicide prevention coordinator for the state. It's a department of one person. That person retired, we got her onto the board. Okay, and now we've got a great relationship with the new one as well. So that also speaks to identifying new partners as well. For American Foundation for Suicide Prevention, I chair a couple of different committees for the state, and one of the things that I'm focusing on a lot is Northern Louisiana. For whatever reason, AFSP has had a lot of problems maintaining engagement with Northern Louisiana, Shreveport, Monroe. And so we've been focusing on it for probably about 2 months now, trying to identify who's doing what up there. Is anybody interested in chairing a walk, joining a walk committee, eventually joining maybe the state board, that type of thing. So identifying new partners, it's important to do it. I always tell them, in the work that I do with suicide prevention, is that you're kind of always recruiting, and you guys will see this when I try to recruit you at the end of this presentation, but you're always recruiting, but you also need to do it systematically too. So this identifying partners for AFSP, we have its nomination, leadership, and also volunteer engagement. We have that committee meeting every other Friday at 8 in the morning, and new activities that help enforce old activities. So one of the things that I'm expecting and hoping from the QPR initiative, again, trying to train 3,600 people in the community on QPR and evidence-based suicide prevention training, is so what we're going to do is, once we get those people trained, and we need to complete that training by June 30th of this summer, I'm going to email them about the walk. Hey, is anybody interested in becoming volunteering for the Lake Charles Out of the Darkness walk? Does anybody have experience with a walk? You want to become maybe a committee chair, that type of thing. So your new activities can reinforce the old activities, okay? And so what should happen, I know that you all know this, but 2020 was hard on all of us for so many different reasons. And so regarding the work that we've done with suicide prevention education, I feel like it did put us back a year, because these new activities reinforcing old activities is extremely important, especially when you're creating something that feels very new in the community. Keeping that momentum going is extremely important, because a year of almost a pause, it set us, and I know that you all know this, it can set things back, quite a bit. All right. So how to get involved is going to be the next thing. And this is there a question there? In that situation, how do you navigate creating a similar entity without burning any bridges or upsetting people? All right. So Megan, are you referring to, I'm trying very hard to be very professional while being transparent while I'm talking to you. So you're talking about the 2 suicide prevention coalitions, and please unmute yourselves and talk to me too. You're talking about the 2 different suicide prevention coalitions?
Yes, sorry, I couldn't find the unmute button. Yeah, I was talking when you mentioned that there was one that wasn't quite as effective, and so another one was formed. Especially if you're someone from like outside the community coming in, how do you, I guess, balance that, making sure that what you're doing is being effective while also not upsetting the community and making them feel like you're coming in and taking over?
Yeah, it's super hard, and I guess I'm kind of sounding like a bully, and that's So that's a great question. So you do it carefully. That's how you do it. Okay. And so because it's important to remember that the people doing, and whether it's suicide prevention or whether it sounds, whether it's about smoking cessation, you've got to always assume that the people involved in the topic care about the topic, right? So you got to do it very, very carefully. There have been many, both coalitions still exist, okay? Both still exist. Both met much less frequently because of 2020, but both still do exist. And so what I think we've all worked to do is kind of differentiate the work that each coalition does. So one is more about dissemination of information, and the other is more action oriented. And that's fine, that's fine. And it is my belief that it would be better to not have even the appearance of redundancy, because what you were saying, I love what you were saying about people coming into the community. You know, if people, let's say we had an influx of people moving in to Lake Charles and they were particularly interested in this topic, you might be like, well, why do you have two of the same thing? But we have had many, many conversations and try to keep them distinct and recognize the value in each as well. Okay. And again, stop me with any questions that you got. How to get involved. And I know that you got this information in your packet. You got additional information beyond just the QR codes. But one way you can get involved is just fill out the walk volunteer application. The application is going to be accepted, obviously. And the QR code will take you there. There's also a tiny URL in the packet that you received for tonight. Just if you are interested in becoming involved in the Lake Charles Out of the Darkness Walk, and it will be this September. September is Suicide Prevention Awareness Month, and it will be September 18th. This year it's going to be McNeese's Cowboy Stadium, so we're hoping for a really, really huge event. Just be real patient if you fill out the application. We're just finishing up the semester, and there's still many things to wrap up with the semester. So we will absolutely get back to you, but we would love to see as many people interested and involved in the walk as possible. That is the other QR code is for the walk Facebook page. And that's where we are encouraging, and we will continue to encourage people to follow us, like it, share the posts. So that's one way. You've got, and again, you've got all this information in your packet. And so AFSP Field Advocate. So field advocacy is, and you've got this information with kind of a blurb about what it means to be an AFSP field advocate. So you could all become an AFSP field advocate. What this does is it's a minimal entry point. Okay, it's a minimal entry point. So you could click on this link, go to the link, sign up, and what you're going to do is you're going to get policy updates and information about what AFSP is doing in the state of Louisiana. Okay, so anything going on with suicide in particular, but also with mental health or behavioral health, and if AFSP is involved, then you're going to get information about that. You'll also get information about once a year there is a state capitol day where AFSP schedules meetings with legislators, and typically we go to the Capitol and meet with legislators. This year and last year was not possible, and of course in 2020 we didn't even have something virtual. This year we did have something virtual, and it's a way to get some face time with the people who can help us make some changes regarding policy, regarding suicide prevention, and also behavioral health. So I've mentioned the QPR training quite a bit. There are many trainings that are great with suicide prevention and education. This is one that we decided to bring to this area because I had not heard of it until maybe 2 years ago, and that was from somebody outside of the area. But if you go to Lafayette, or if you even go to Northern Louisiana, everybody who is involved in behavioral health, mental health has heard of QPR. Everybody has, if that is their world, their discipline. But I feel pretty comfortable saying in this area we had not heard of QPR. So we've got in-person sessions and the virtual sessions here, and this should also, this flyer was attached to your information for tonight too. So I strongly encourage you to go through this training if you have the time. It's a short training. You can get trained in about an hour. Again, the trainer cannot deviate from the information on the slides, cannot. So is it the most engaging training? I don't know about that, but you are going to get basic information that you will be able to build on if you decide to go on and do another training. There's lots of great trainings. There's Safe Talk Assist. I'm hosting a clinician training specifically for LPCs. Either this fall or in the spring. I'm going to a CAMS training in Baton Rouge. So there's lots of great trainings out there. This one's a nice entry point, just because the time commitment is small and you're going to get the basics. All right, and if any of you have any questions for me, that's the number for KDCC for 755-981. McNeese was significantly damaged because of Hurricanes Laura and Delta. The building that houses the psychology department and my 2 clinics is going to be torn down. We were in a church in St. Luke Simpson Methodist Church on Country Club from November up until last week. And so we just moved into modular buildings back on the campus right near Cowboy Stadium. So I'd normally have a phone. You can call KDCC though, and they will get the message to me. And you can feel free to email me as well. All right, so, well, okay, 7:50. I do hope some of you might have some questions. Feel free to speak up. I know I covered a lot. I hope I gave you the way the model works based on what was created in the state of California versus the way that we came about things and then found the model as well. I will say that I think both ways are very valid. You know, I'm sure it's great to have a well-funded initiative from the beginning and then be able to work that model. But it's also, I mean, it's exciting to be able to try to bring something new or new-ish to a community and figure out who your partners are and to be able to create things with them along the way and watch things change as you're engaged in it. Are there more QPR trainings after May? Yeah, so the money that we receive from the United Way, we need to spend it on these trainings by the end of June, okay? Now, obviously, the United Way understands, because it's the Southwest Louisiana United Way, they understand that what is happening in this area because they're physically in this area. So we may have the money for a little bit longer than that, but we're really trying to make sure that we meet our goal of training 3,600 people in Southwest Louisiana by the end of June. We're trying our best to absolutely do that. We're not saying that QPR is going to go away because again, maintain is the last part of the model, right? So we will have people who are trained as trainers, because that's what we did. We trained 60 trainers who then had to commit to going out and training 60 individuals in the community. All right, we had to shift and change the model based on COVID. Then we had to shift and change the model based on Hurricanes Laura and Hurricanes Delta. But like our goal is still 3,600 people. So we will have trainers trained in this area, and we will still have some money to pay for additional materials to train beyond that as well. We will be looking at some additional trainings when we submit our application to continue to become a United partner agency. We've got to do the letter of intent, I think, within 2 weeks, I believe. All right, what other questions? And please speak up. You can use chat if you want to, but please unmute and speak if you like to. Well, if nobody has any other questions, I guess that is it. I do encourage you, please contact me if you've got questions. I imagine it was probably a lot of information about suicide prevention. I've got a lot more if you'd like to talk. And you can always call KDCC, and I do hope that some of you might be interested in getting involved. We'll definitely need volunteers for the walk in the fall, and we'll need those volunteers sooner rather than later. So it won't be a matter of waiting until September. There are any number of different ways that y'all could get involved. I know that I imagine that many of you are interested in research. I just got my IRB application approved to conduct some suicide prevention research in the community. When you look at general statistics, it seems to be a white problem. The person most likely to die by suicide is a middle-aged white male. And so if we only look specifically if we're focused very narrowly on that that demographic, then we're going to miss the story. And so the research that we're going to be conducting is research with attempt survivors, which I've found very little research with attempt survivors. In fact, the word survivor typically is used to refer to somebody who's had a loved one die by suicide or make an attempt. But so we're going to be talking to people who have attempted not within the past year, and there's lots of protections in place. And we're going to be looking at speaking to 8 people in 5 different communities, Black, Hispanic, LGBTQ, veterans, and the service industry. I found that the suicide rate is very high in the service industry, so bartenders, servers, that type of thing. And we're going to be collecting we're going to be doing quantitative research, but also qualitative as well. We've created a semi-structured clinical interview, which I was stunned to find out that didn't exist with suicide already. And we're going to be hopefully helping people to tell their stories. And we're going to see what we find out about that. That's going to be kicking off probably in about 2 weeks, I would imagine. All right, well, thank you all.
Thank you.
Thanks.
Thank you, Dr. Yardis. We appreciate you taking the time to do this for us. I know Robin will be following up with everyone after this is over, so you are free to go.